So, hi everybody. This is we're recording this talk for possibly other clinics and folks that can't make this talk. So just be aware of that. I'm Danielle Loeb. I'm a general internist here at the Anschutz Clinic, and the lead for the GIM trans and gender diverse care. So this talk is specifically on kind of a little bit of the nuts and bolts and an overview of risks and benefits to providing actual hormone therapy. So gender affirming hormone therapy. I need to thank many people who I stole from for this talk. So Sean Awamoto, David Saxon, McCall Rothman, all members of our endocrinology division here, and then Helene Hedian, who is another general internist. So I have no conflicts of interest, but you should know that almost all the medication uses discussed here are not on label. It's all off label. So what are we going to talk about? You're going to learn about the meds, how to use the meds, what are the meds for gender affirming hormone therapy in adults. I'm not going to touch adolescents. And then monitoring strategies for gender affirming hormone therapy, and also some primary care for folks on gender affirming hormone therapy. And then I want you to feel like you have an understanding of the risks and benefits, complications of gender affirming hormone therapy. Just a touch on terminology, which we went over on Tuesday. So gender identity, just a reminder, is a person's self-identified gender. And that may correspond to how they look externally. It may respond to how the sex they were assigned at birth, and it may have nothing to do with either of those. So it may not be visible to other people. It is a self-identification. Sex assigned or recorded at birth is what somebody put on your birth control, on your birth certificate. It's maybe related to chromosomes, most likely your gonads. And then gender affirming hormone therapy, as we just said, are the medical therapies. And then gender affirming surgery are the procedures people may utilize to affirm their gender identity. So there's three major guidelines we use, and I refer to these regularly. I myself use the primary gender guidelines for primary care providers that were put out by UCSF. They're very easy to read and look at, to tell you the truth. Although we do have some recommendations that vary a little bit from theirs in some of the handouts and references I'll be giving you. So that's a little caveat to those handouts. The Endocrine Society are the safest, I would say, to use those. You can just Google Endocrine Society gender affirming guidelines, and you'll get the full guidelines. And then WPATH is sort of the closest, I would say, to a regulatory organization. So WPATH will put something out, and then insurance companies tend to comply, or we tend to shift practice. So there's a relationship of pushing the WPATH and WPATH kind of putting policy. So for example, around mental health assessments prior to starting gender affirming hormone therapy, it's been changing widely, over the last decades, and is about to change again with their new guidelines. And so they're more of that kind of agency, if that makes sense, or organization. You can also, I will say, like WPATH, if after this talk, if you decide to become a to provide these hormones, you can sign up with them and your name will be on a list of providers. You don't have to be a member to get your name on that list, and patients look at it. So this is just an overarching notion, and I'll try to take you through a little bit of the how-to nuts and bolts of providing this care, and then Allison, if you don't mind muting people if they start making noise. So I'll give you a little bit of the nuts and bolts, and then largely it'll be sort of an overview, bigger picture. So this is in the nuts and bolts category. So basically, you see a new patient, they say, I want to start hormones to transition. There's some things you need to kind of check off your list. So for reassurances, you'll get a sheet with this information. It's coming out in the next couple of days. I'll be emailing it to everybody. But you have to diagnose gender dysphoria. Maybe somebody already has diagnosed gender dysphoria, a psychiatrist or a psychologist, a mental health provider. They may come in saying they have a letter. So we're going to look a little bit at what that diagnosis entails. You can do it as a general internist, and we often do it. Maybe you would refer to a mental health referral if you feel like this patient has serious mental illness or needs like extra support during transition, or if you have some questions about the diagnosis. You're going to do an informed consent for gender affirming hormone therapy. So we have an information sheet that we review with the patient, and it's this, patients know it. It's like known in the community as informed consent model. That's basically what we're using here at the university. So what that means is they don't have to go through a gatekeeping psychiatrist to start this, or psychologist. And that is consistent with the new WPATH guidelines. And then some other things you're going to do before ever starting hormone therapy. You're going to assess their other health conditions, see if there's meds that will cause interactions or anything you need to get under better control, like hypertension. You're going to determine fertility goals. You may need to refer for fertility preservation prior to starting for trans women. And then you're going to collect baseline labs. So that's all before you start. So we're going to go through all of those pieces kind of now, that kind of how you start, what you're going to do before you start. So the criteria for diagnosing gender dysphoria, and please use that diagnosis when you're in the chart. There's a whole talk that Dr. Davies in psychiatry gives of the depathologization of gender dysphoria, and we have only come so far in America. So you'll see number 1, persistent, well-documented gender incongruence or gender dysphoria. You cannot use gender incongruence in America. Okay, that's only in Europe that they have advanced. Basically, and gender incongruence means it's not a disease. It's just a state of being where the gender identity doesn't match what they were assigned at birth. Whereas gender dysphoria is distress, unease, gender incongruence. It does imply some kind of disease. So Dr. Davies often describes incongruence as like red hair. You know, this patient has red hair. Their gender is, you know, incongruent with what they were assigned at birth. So ideally we'll get there here in America. We're not there yet. So please diagnose gender dysphoria. They have to have a capacity to make a fully informed decision, consent for treatment, age of majority, which no problem for us, and then mental health concerns. So this is changing, must be well controlled. In the new WPATH guidelines, that even gets downgraded beyond must be well controlled, because often this is how you control their mental health conditions, by treating their gender dysphoria. So just know that is coming. And I have dot phrases that I will be giving you, templates that basically go through the pieces of documenting gender dysphoria. So mostly it's a long-term sense of gender being different than that assigned at birth, and some distress associated with it. So these are our sort of quote unquote consent. They're actually information sheets. They are official forms of UC Health. Paper versions of them are currently hanging in the resident room and sitting in my office. They will be accessible through Epic, through an Epic like resources for providers, hopefully in the next few weeks. And then I will be emailing these to you as well. If somebody has a bright idea of like where I could put them for the most providers, please let me know. But basically, they're full of information. They're great. They're two-sided. You go through it with the patient. Patients often know all this, but you still review it with them, and then they sign it, and you upload it into their chart and give them a copy. So it includes a lot of the information we'll go through here. It goes through the changes, what to expect, and then also some of the risks and benefits, which are on the other side. And they're different for masculine and transfeminine. So this is a little bit about the role of mental health. So for years and years, it was a gatekeeping role. I'll say, like at Kaiser currently, they still do this. A friend of mine had to have the 3 or 4 visits with a psychologist before, to answer this like whole series of questions. So currently, we have shifted. So to a support role.
Repatha. I don't know anything about Repatha.
Please mute if you can. So now it's more of a support role. Is the patient ready for transition? So if you have real questions about whether they're ready, if they're going to need extra support, transition is a big deal in someone's life. It's okay to say, I think it'd be good for you to see a therapist, or for you to see our mental health clinicians in the transgender clinic. That's okay for you to do. Or if you're like, I'm not 100% sure this patient has a ton of trauma in their life and serious mental illness, and I'm just not 1,000% sure that this is gender dysphoria. It's okay. We have those resources. You would refer to endocrine and put in the referral for the transgender multidisciplinary clinic to see mental health, to do that. So why do we treat? What's the point of gender affirming hormone therapy, and what is this about mental illness? And so this is a very small study, but I think it's quite compelling. This is a study in which 17 patients, which were 14% of the larger study, the first one had a DSM-4 diagnosis with a psychiatric comorbidity, and basically they found psychiatric distress and functioning impairment were basically more significant before starting hormone therapy than after therapy. So basically anxiety scores were above the normal range, and they reduced for anxiety and depression symptom rating scores. And then in 2-year follow-up for those receiving gender affirming therapy, they found significantly lower subjective levels of gender dysphoria. This is for people they followed from start. Body uneasiness, depressive symptoms compared to those without, just by being on gender affirming hormone therapy, regardless of if they had had any changes. And then for those that had actual changes from their therapy, they were starting to see objective changes. They even had better outcomes. So patients, it improves depression, it improves anxiety, doesn't make it go away. Okay. All right. So, and another reason I give this Tuesday in the talk, I just think this is a really important slide. This is a patient who had to educate their providers from a qualitative study, a 26-year-old Black trans patient who took the time and energy to educate an insensitive provider. And the provider is just like, so the patient is like, you're going to have more patients like me. You're going to have more clients like me. You have to learn this. And the provider is like, well, I've never seen this before, and the patient is like, yeah, but here we are. So I would say that's where we are. For me, it is an absolute joy to care for these patients. It has given new life to my entire practice. I love it. But if that's not your case, I will say you're also just a provider for all patients, and we need to wrap our arms around all of our patients. So some specifics of care. So I'm going to talk about it as masculinizing or feminizing. Within masculinizing hormone therapy, you could take a binary approach. Some patients take a binary approach where their goal is to quote unquote pass. Sometimes they'll say, they identify, if you ask them how they identify, they might just say, I'm a man, I identify as male. It's a binary. So assigned female at birth, I am actually male, and help me get there. And then there is more of a non-binary transmasculine approach, or we referred to yesterday as gender queer, maybe. And that is that can be a much larger array that can include people on hormone therapy, people not on hormone therapy at all, maybe people on lower doses. I find that people have very specific things they want often if they're non-binary. Like I want facial hair and I want to drop my voice and then I'm done. So maybe they'll be on testosterone for a year. Or I want top surgery. I don't want any hormones. I just want top surgery. And so this is really important because one of the first questions when you see the sort of templated HPI I give you is, what are your goals? So it's really important just to ask patients. It's always with all these questions. It's what are your goals? Share with me what you're interested in. And usually patients will be pretty clear with you. The goals may change over time. I had a patient that was very non-binary. We were going to start low. And they were like, once I started, it became totally clear to me that I'm a man and I want full transition. So just be open that these things can change too. So what are the hormones doing for them? So the beautiful thing about testosterone is it does a lot. It changes their voice, unlike estrogens, facial hair, it does some bad things. Acne is can be a really big problem. So just know that that's one of the things you're going to have to manage often. And then other things patients generally want is cessation of menses. It may or may not do that, and we'll get into that later. And then clitoral enlargement, vaginal atrophy, another sort of negative often. And then you can see this timeline. This timeline is also in our information sheets. It's really important to talk to patients like what to expect and when, because often when folks have made this decision, they want the changes to happen really fast. And you can see that the maximum changes, like in muscle mass, that's the one that takes the longest, and fat distribution, those kinds of body changes, they just take some time. So again, this is the same kind of thing. What are their goals? These are often the biggest goals. And then what do we have to offer? And now we'll get into a little bit injections versus gel versus patches, and a little bit we'll touch on some of the other options out in the world. So the big ones, the ones we prescribe, the ones you would prescribe would be testosterone cypionate or anaphthate. Sorry for my pronunciation. Generally, you're going to prescribe cypionate, and sometimes the pharmacy won't have it. The cool thing that you may notice in the third column here, it says IM or sub-Q. I need to fix the slide, but sub-Q is possible. So that's big. The doses don't change, whether it's IM or sub-Q. And then usually they're getting it weekly. So it would be, you would start at 50 with a max dose, usually around 100 weekly. Or sometimes patients have really hard time remembering and they'd go to every 2 weeks. So it's double the dose and, double the time. You always are going to measure when you're measuring, generally mid-dose peak. So I mean, like you're going to measure like 3 to 4 days after if they're on weekly dosing, just FYI. We do not use undecanate. It's, you have to have this whole special procedure. We don't do it. It's nice because it's every 12 weeks. You get a lot of part of the joy of it is you get a lot of basically teenagers. You get people that are 18 to 25 and they're sort of teenagers. So some of them really would like to only have to do something every 12 weeks, but we don't do that here. Gels, just note that depending on the gel, and the gel that you get is going to depend a little on the pharmacy. There's a back and forth here. The doses change a little bit. In your one-pager sheet, I'll have all this for you. Also the UCSF sheet has really good, has this as well. And then patches. I almost never use patches. I always usually almost I'm using testosterone cypionate or gel. The gels can be an issue because if they're sexually active, they can't get it on their partner, and if they're physically active, it can wear off. It can also cause a lot of acne and irritation. So oral testosterone we do not use because of liver toxicity. And then there's not, people use pellets and buccal, but there's no data on that. Sub-Q is very exciting. IM is 1.5 inch needle. So sub-Q is a 5/8 inch needle. A lot of patients choose this. We have seen actually in our clinic, our nurses have been having to work with patients a little bit on some abdominal irritation if they're doing the sub-Q. So from those injections. So some people will choose to do IM, but just note that basically there's no difference in testosterone levels when you use sub-Q and IM. So I generally recommend sub-Q initially. So what are the risks? I'm gonna spend some time with this. I feel like as internists, we really need to know what the risks are for things. And then all the little details of exactly how do I prescribe, I hope to provide as much of that in these sort of resource handouts as I can. So this is an overview, and then I'll go through some of the data. So most likely, well, pretty much everybody, I'll say, gets some erythrocytosis. We had a talk on Tuesday morning about erythrocytosis. I was really happy that the hematologist on Tuesday morning was like, yeah, we don't 100% know what to do. And I would say that's a little bit where we're at. So you are an internist, you can use your judgment here. Basically, my practice is if the hematocrit starts to get above 50, I start doing a workup. So this is a little higher. This is endocrinology. I'll work up, are you smoking? Are there signs of sleep apnea? I don't do the JAK2 mutation much, I'll say. Especially I'll try to check a CBC beforehand, and if it was normal beforehand. If the numbers are extraordinarily high, and it's not matching and the testosterone is still like 200, then I'll think about like, okay, do I need to look for, other causes? Above 55, I either back off the dose or I will maybe have them give a blood donation or do phlebotomy. I know that Dr. Rothman says she almost never does that. She'll do everything she can to just get it down below 55 without doing phlebotomy. So likely increased is weight, acne for sure, androgenic alopecia, male pattern baldness, and sleep apnea. Possible increases are lipid abnormalities. It's usually triglycerides actually. And then maybe, but looking more and more not, cardiovascular disease, hypertension, diabetes, and probably no worsening is osteoporosis. And then we really need more studies in general cancer screenings, and then liver abnormalities. So this is a study that was scary. And it is not a study that we want to hang our hats on that much. So this is a study of folks in Europe, and basically it showed this huge increase in mortality. But look at the number of smokers. You might see these numbers, and I just want you to be kind of familiar with this study. You can see they're very different from US populations. 86% had gonadectomies of the trans women and 94% of the trans men. Those numbers are way less in America. And then smoking, the numbers were really high. They didn't control for risk factors. So you have all these smokers and they didn't control for it. And you can see their death. So that was like generally their high rates of death, but a lot of the causes are HIV/AIDS or external drug use, like illicit drug use, things that are not related to the hormones. So from these sort of low quality, there's a meta-analysis from these sort of low quality European studies, all of which are really not great. You saw this increase though in triglycerides, insufficient data still for MI stroke, venous thromboembolism mortality, and some increases in blood pressure and body weight. So we have a better study. It's good news. This is the US study done at 3 Kaisers in California and Atlanta. It's the STRONG cohort. They followed patients prospectively. Some had already been on hormones. And it's quite large. The transmasculine cohort, which I'll talk about now, was about almost 3,000 people. And then they matched times 10. So you can see like the reference men, they matched to men, cis men and cis women. It's not the most diverse, but it's more diverse than European studies. 24% smokers, so you see less than the European, and then the gonadonectomy was only 11%, so it's drastically different. And so this is what they found. So this is just looking at the transmasculine cohort. They divide it up into those overall and those who actually started testosterone during the study. And that's just because there's some theories that these risks are highest in the first couple of years of starting therapy. And you can see when they compare for venous thromboembolism, ischemic stroke or myocardial infarction versus cis men or versus cis women, none of them are statistically significant. So, and that is included also, you see sort of a trend towards higher numbers here, but again, no statistically significant difference with cisgender men or women and the transmasculine patients. So for me, this is really reassuring. So this is the sort of, just look at the transmasculine line here. In summary, basically we think there's no real difference for ischemic heart disease, cerebrovascular disease, maybe increase in blood pressure, no increase in venous thromboembolism. HDL goes down, maybe, and triglycerides often go up, and then diabetes pretty neutral. So that's fairly reassuring, hopefully. What are some other things that are less like, very most important is aggression. Patients worry about this. It's always a conversation piece for some patients that have like bipolar disorder or anger management issues. Sometimes we'll actually start lower doses. So like instead of starting at 50 IM, we'll start at 25 just to see how they feel. Everybody I've done that with writes me in a week or two and says, I feel fine, let's go up. I have personally yet to have somebody really struggle with this. So in these studies, it's pretty mixed, actually. They're small studies. These are all European studies, but 4 of 7 reported increase in aggression. 1 of 7 reported a decrease. So it's a little mixed. It's something to talk about with patients. This is something that you might, if you're getting some consults. So this was nice. This is about if we could continue testosterone perioperatively. It causes quite a bit of dysphoria. I've had patients, they end up being off of testosterone sometimes for like a month for surgeries. And it basically, based on this study, there were no events, no venous thromboembolic events for patients who were maintained on their testosterone perioperatively. So, you know, who knows if the surgeon will listen to you, but patients should not have to go off testosterone for surgery. So back to our little timeline here. So you did all your labs, you talked to your patient, they did the consent, everything looks good. And so you started hormone therapy. When are you going to see them back? So generally you see them back every 3 months, at least you check labs. every 3 months until you get to goal. And we'll talk about what labs you're going to check. You're looking for side effects, and then just checking in on how they're doing, with their general transition, and then doing whatever other medical care you need. So the big ones you're monitoring are the hemoglobin hematocrit because of this erythrocytosis, and then testosterone levels. And then you get a huge range in all the recommendations. Basically, UCSF says just follow UCS path recommendations for lipids, weight, blood pressure, just follow like you would anyone else. And then for osteoporosis, basically the big concern is if they stop their testosterone and maybe they've had a gonadectomy. That's when you really have to worry about osteoporosis, like no ovaries and they're not on testosterone. So we'll go through these a little bit. And then just as you go ahead, you're going to continue. Maybe after they hit their goals, you'll check labs in 6 months, and then you can move to a year, essentially. So primary care. One thing is for transmasculine patients, you want to ask them about fertility preservation, but you can do it after starting because it is reversible. So testosterone does not cause irreversible sterility. And then, although obviously it would be a big deal for patients, so they might want to, if they really want to have children from their own eggs, they may want to do that in advance. Don't forget about contraception. Testosterone is not a contraceptive. It may stop their menses, it may, but you can't treat it as such. So please, and again, they're often 18 to 23-year-olds. And try to talk to them as much as you can about what organs are going where. You really want, are you having sexual intercourse with someone with a penis, and is it going in your vagina? You really want to have that kind of conversation with patients. I had a patient who's 19 who wrote to me. It was so cute. And I was like, I think you wanted to know, I'm about to start having PNV sex soon, but you kind of want your patients to be able to talk to you like that. Because identity, again, is not going to maybe be relevant. So don't forget about PAPs. PAPs can be traumatic. There's a lot of ways to handle that. You can have their partner present. You can offer an anxiolytic. You can refer to gynecology. There are 3 gender affirming gynecologists here, and you will have that referral list. Breast cancer screening, basically same as cisgender women. I have a whole talk on that we're uploading to the website on primary care. It goes into it in a little bit of more detail. If they've had a mastectomy, there's variable recommendations, essentially. Some recommend, Endocrine Society recommends palpation annually, and UCSF recommends a conversation with the patient. But before mastectomy, before top surgery or chest masculinization surgery, you want to treat them like cisgender patients. And just don't forget about HPV vaccination and other vaccinations. So I will try to speed it up a little bit here. This is the increases in hematocrit. The point of this slide is basically that trans men went to cis male levels of testosterone, of hematocrit on testosterone. I find it goes higher, to tell you the honest truth. And I think it has to do with being an elevation here in Colorado, because they often pop up above the normal male range. So this is important. Cessation of menses. So I will ask on follow-up, are you still having menses? It can take 6 months for testosterone to get their testosterone to a level where to the physiologic male levels, which is 400 to 700, where you could expect cessation of menses. Some patients, it'll stop in 2 weeks. And then other patients, you're at physiologic testosterone levels and they're bleeding. We tend to use progesterone in various forms. And you can just see, I just want to show you this. basically, the longer they're on testosterone, so the more months, the more you get to no bleeding and the less progesterone use. So it's not permanent if you have to start progesterone. A couple of other notes here are that predictors of ongoing bleeding are lower testosterone levels. So you can always try to get their testosterone to the 400, 700 range, and gel versus injection. So sometimes just switching them to injections can stop menses. You can always consult gyne on this. I tend to use agestin, norethindrone. That's what our gynecologists recommend. And you can titrate that up to like 10 milligrams. You could start at 2.5 milligrams and titrate it up to 10 milligrams. So the treatment options are increase the testosterone dose, change the route to IM or sub-Q, progesterone, oral or parenteral even, GnRH agonist. We don't tend to do that. I would refer to endocrine if you were going to go that route, and IUD, but of course IUD can cause some irregular bleeding. And then there's non-hormonal approaches, which often I'll end up getting, if the bleeding doesn't stop, we'll get an ultrasound. They'll often have fibroids, and then they'll end up getting a hysterectomy, usually because they want the hysterectomy as well. So some bone notes. This is from Dr. Rothman and Dr. Awamoto here. So just a little bit about what testosterone does to the bones. Just an interesting point. So trans men start at the same as cis women in their bone density. And then if they start testosterone over 40, they get this bump in bone density, probably because they've already lost some by that time. But if they start under 40, they don't get a bump, but it just stabilizes. So generally, as long as they're on testosterone, their bone density stays pretty stable. And so you have to kind of worry about it when they're off. UCSF just recommends same screening as cis women in these patients, though, in terms of DEXAs. What happens if they've had a gonadectomy? Maybe you can use a lower T dose. But usually it's lifelong that they're using some kind of testosterone, unless they're non-binary. Actually, I have a lot of patients that are like, I'm happy, I'm good. So trans feminine. Again, you want to talk to them about their goals. Are their goals binary? Are their goals more non-binary? What specifically are they looking for? What treatment options do we have? Generally, everyone is going to need both estrogen and an anti-androgen. Estrogen does not do it alone, basically. So in terms of estrogens, just know that, so oral, the guidelines say 2 to 6. Almost no one stops at 6. UCSF guidelines go up to 8. And most providers will go up to 10 because you have patients that are rapid metabolizers of estrogen orally, and really you're worried about the level. So you're aiming for 100 to 200, again, cis, normal physiologic cis female levels. And if they're not at a high level, you're not putting them at risk. But the guidelines are going to say 2 to 6. If you've gone above 2, you want to split it up into twice a day or even 3 times a day. Transdermal, you can start as low as 0.025, but 0.025 is the equivalent of like half a pill of the oral, just so you know. And then really the limiting factor is the patches themselves. So you could go up to 4 patches, but nobody wants to wear 4 patches. The patches you want to use semi-weekly, so they change it twice a week. There's these V-Val dots that are smaller. We love patches. Patches get you the best results. It's because it's this steady, it's the lowest risk in terms of stroke, and patients don't like them because they're patches stuck to their body and they might react. So if you can, talk to them about patches, see if they're open to them. And then parenteral is only IM for estrogen. There's not sub-Q in estrogen. So these are just whether they're weekly or biweekly. This is actually where the UCSF guidelines we differ from. And again, I'll give you the handout. They have different dosing for valerate and cypionate, and we don't recommend that. We recommend the lower doses for both. So you'll get that. And then antiandrogens, the only one you need to know right now is spironolactone. That's what you're going to be using. This one is only in Europe. And then GnRH agonists, I refer to endocrine myself. Do not use ethinyl estradiol. That was what we think caused a lot of the strokes, cardiovascular, et cetera. So you're not using that. So again, talk to your patients, listen to your patients, see what they're interested, what are the changes they're interested in. These are the expected, so notice no voice and no hair change. So they're gonna, trans feminine patients generally have to do more, unfortunately. Like they're gonna have to do speech therapy or even have surgery for voice changes. They're gonna have to do electrolysis or laser to get rid of hair on their face, etc. It will help with hair loss, estrogen. So notice the timing. For example, breast growth starts in the first 3 to 6 months. They'll get some tenderness, especially in the beginning, but it takes 2 to 3 years. And then the other big thing is, where is it? Basically, they become sterile, so decreased spontaneous erections and decreased sexual desire. And then just note that they can become sterile on irreversible sterility on estrogen. And this is on that handout. So just some notes that physiologic doses of estrogen alone are not enough. You need to suppress testosterone. Don't use the ethinyl estradiol, please. And then oral estrogens are probably more thrombogenic. So if anyone has a risk factor for cardiovascular disease or for blood clots, you're going to not use that. You can use patches or IM. So the antiandrogens, right now we'll just focus on spironolactone. It says 100 to 300 a day. I start at 50. The doses are higher than you're used to using in your patients for hypertension. We also start it and then check it in 3 months. So that was something for me to get used to. I don't check it a week or two after. It's really rare that you actually see hyperkalemia. Patients don't like spironolactone often. It causes some dizziness, lightheadedness, etc. So I'll talk to them about that in advance, and then that's often what there's a lot of communication around. Again, they're often young patients, not with hypertension. If it really isn't working for them, then a GnRH agonist is very effective. It's just that they're very expensive and there's some risks. So for now, I refer to endocrine for that, and that's fine if you want to do that. This is just a review to say, like, we don't know what works best. So these are all practices, kind of best practices, what people are doing, you know. So this is a study where we did not identify any completed studies that met our inclusion criteria, which is what assess safety and efficacy of hormone therapy. So we're just still learning a lot. So just know that this is a field in process. And then again, sterility, just don't forget before you start for trans feminine patients, you want to talk to them about cryopreservation and make sure they get that before they start hormone therapy. And then what are some other things? You will be asked about progesterone. I will tell you, I started, our practice in the endocrine clinic is after a year. You don't want to start progesterone in the first year because it will actually, generally patients want it to increase breast growth, and it will increase ductal development, or it'll help with the ductal development, but it will impede it if you start in the first year. So I'll start it, but don't feel like you have to. It's not on our like routine sheets. You can refer to endocrine for that. There are, very specific methods and very specific approaches out there in the world that are not evidence-based. So you'll be asked about it, the Powers method in particular. And just don't feel pressured. Just say, I'm going to refer you to the specialist for that. But if you're comfortable, you could have a conversation with them about potential side effects of progesterone, and you could start it if you want. It's in the UCSF guidelines. You start at 100 and for micronized progesterone or medroxyprogesterone 5. The issue, just so you know, with the 5-alpha reductase inhibitors, you cannot follow testosterone levels. It may actually increase testosterone levels. So it's a little complicated if you try to use these. I found them also not to be very effective, and they can cause some depression. So we don't push it. Sometimes people are on finasteride for hair issues. Okay, risks. Most likely increased venous thromboembolism. This is different than testosterone. There is a increased risk, okay? Likely increased triglycerides, gallstones, weight gain, likely increased cardiovascular disease, maybe, but like strokes, it's the strokes that are likely increased. And then possibly high blood pressure, hyperprolactinemia, diabetes, osteoporosis, not likely worsened, and we don't know about breast cancer much. We know some. You can see my other preventive talk for an in-depth on that. So this is that summary. So maybe increase in ischemic heart disease, yes, increase in strokes, okay? Let that sink in. You're gonna have to talk to your patients about it. Now, I'll just say the increase in strokes, does it equal the increase in suicide in patients that don't get this therapy? No. Okay, so that's why we're doing this therapy that does have risks, but you do want to have an honest conversation with your patients. Increased blood pressure, increased venous thromboembolism, and the others are maybes. So these are real. And so this is that same study. We're not going to go through that. We're not going to go through this. So we're going to go to the cohort study, the STRONG study in the US. So this is that same kind of slide where we compared trans feminine patients, the full cohort, and then those that started estrogen during the course of the study, and compared to cis men and cis women. So in the overall cohort, they found a increase, so 1.9 adjusted HR in for venous thromboembolism compared to cis men and 2 compared to cis women. So this is real. And then if you look down at those who started estrogen, it's higher, 3.2 and 2.5. So it's a risk. Strokes, they actually didn't see the risk after compared to men, cis men, in those that had already been on it for a while, but they did see it compared to cis women. And then, and you can see there is basically an increase when in the cohort that just started. So there looks to be a bit of an increased risk when you just start the estrogen. So again, this is venous thromboembolism and this sort of cumulative index compared to reference men, and the slides for ischemic stroke look very similar. So over time, there is a risk. So what do you do? So what do we do about this? We assess for risk, and we reduce risk wherever we can. Strongly encourage smoking cessation. I screen 18-year-olds for lipids. All these patients, and McCall Rothman will say all the patients, transmasculine and transfeminine. I wasn't really doing transmasculine. Before you start, you're getting lipids, you're getting an A1C, it feels over the top. You're checking them again after 3 months, and then you can kind of leave it be. Blood pressure control, and so that's for everybody. So what if they have a family history of thrombosis? Really, I'll tell you what I do is I refer them to heme. We have like 4 different hematologists here that have expertise in particular risk of thrombosis and hormone therapy. So they see them quickly. And usually I can get them seen in a couple of weeks. So I won't start it at first. And the question is not, can they start or not? It's, do they need to be on a blood thinner? Do we need to do something to mitigate risk if they have a family history or a personal history? And then you're gonna maybe, post-operative prophylaxis, you're gonna do things after hospitalization. But basically I work closely with heme, and our hematologists are really helpful. You're gonna want them on a patch if they have a family history, patch or IM. You're not gonna give these people pills. And then we'll get into some of the routine stuff. So what are you doing every 3 months? So for patients on transfeminine therapies, you're going to check testosterone and estradiol every 3 months. You want the testosterone. This is under 50. You could say under 55, ideally. And then estradiol needs to go between 100 and 200. The lipids, weight, blood pressure, again, it varies based on society. So here I would say we tend to be more conservative, and we're pretty tight on that before starting, and then at 3 months. And then after that, just use your judgment as a primary care doctor. Electrolytes, you're gonna monitor those if they're on spironolactone, and then osteoporosis, generally go with cis women recommendations. Breast cancer is not on here. I think it comes up in here. So again, contraceptive counseling may not prevent pregnancy, even though it can cause sterility. So you still want to talk to them. Screening, they probably have a prostate. Keep it in mind. If they have an organ, whatever organ it is, you screen it if they have it. Generally the risk is lower for prostate cancer because their testosterone levels are lower, but just use your brain like you would in a cisgender man and talk to them, etc. Breast cancer screening, basically if they've been on hormone therapy for over 5 years, screen like a cisgender woman. That's the easiest way to think about it. And fertility, again, we already talked about. So I have again a whole nother talk on preventive stuff. So if you want it, it's 30-minute talk. Again, breast cancer screening over 50 and or if they've been on estrogen for over 5 years. They don't recommend, they used to recommend screening for prolactin, no more unless there's symptoms. You don't look at total estrogen levels, just E2, and screening for clotting disorders. HIV, please don't forget to counsel to find out who they're having sex with, what organs the person has, and where the organs are going. Rates of HIV among trans women are really high. 24% of Black trans women have HIV, really high. Usually patients are really open to talking about it. You can always refer them to the ID clinic for PrEP or provide PrEP yourself. Bone health, this is interesting, I think, especially with debates currently about whether trans women should be able to participate in sports. You can see that cis men and trans women, look at what, this is before a hormone has ever gone in their body. They start with lower bone density. So there's a lot of positive causes like depression and not being active and not participating in sports. So they start out at a deficit, but actually being on estrogen helps. And at 10 years, they tend to hold that increase. Oops. But the general recommendation is to screen for bone density like you would a cisgender woman. The big risk comes if they're off of estrogen and they've had gonadectomy. So sort of similar if they don't have any sex hormones. So I'll just say with this slide, the UC Health Integrated Transgender Program is available to you as you start this. So via me, but you know, by now our nurses have met Kylie Fisher. You've met Kylie Fisher. You can send her an email in in the regular email, like, how do I get this patient in? But we will, I will by next week send you an email with like how to make referrals in all these one pagers. And then, and you can always refer just to endocrine for transgender care and say what you're wanting in the referral. So we are here for you. Okay. So with that, we actually might have time for maybe one or two questions. I'm here, so happy to answer questions if I can figure out how to stop sharing. Here we go. Oh, I see in the chat. Oh, good. It looks like Rita was answering some questions. So there was a question why you would choose IM sub-Q over gel, because the gels are really irritating to people's skin. And also, if you're sexually active, it can get on your partner. So you have to make sure not to have it on your skin for a few hours before sex. And then also if they do a lot of sports, those are the big reasons. Also, they have to remember, it's again, that adolescent thing, and it's easier for them to remember to take a shot once a week or once every 2 weeks than to put this gel on every day. Trouble getting a PSA covered in a trans feminine patient. Oh, that's interesting. That is really interesting. I don't know the answer to that question, Rob. I haven't had that problem. I have ordered them, but they may not have had their legal sex changed in insurance. We can raise that to insurance folks and see what to do. And then, so patches and IM estrogen aren't considered thrombogenic. They are. It's all thrombogenic, but it's less thrombogenic than the pills. Oh, and Rita answered. Okay, great. Any other questions?
I don't think so.
So I'm really glad to see all the nurses here, because I just felt like you're going to see these results. You're going to, people are doing cross cover. There's all this. It's just, maybe eventually, there'll be some protocols. There's no expectation of sort of protocolized doing anything. Just feels like understanding the overarching medical background seemed important. For now, all this information is up in the, like I said, in the resident room is where I'm actually physically putting something. If there's anyone on this call in this meeting